My name's Noel Clark. I'm a consultant urological surgeon and I work in the Christie Hospital and the Salford Royal Hospital in Manchester. And my specialty interest is in cancers of the genitourinary tract. What I'm going to talk to you about now is the STAMPEDE study in high-risk and metastatic prostate cancer at first presentation in patients who are hormone naive. This is a groundbreaking study in a number of ways. It's been coordinated within the UK with some help from Switzerland. And what it has done is attempted to improve the treatment of men who've got high risk or metastatic disease at first presentation. And it's done that in a unique way, using a multi-arm, multi-stage approach to cancer trial design. This is the first time ever that this trial design has been used in a cancer trial in the world. And STAMPEDE has been enormously successful in recruiting patients through the UK to this study. Currently we have over 7,000 patients in the trial and it is ongoing. Recently what we have done is reported on the use of combined therapies using cytotoxic chemotherapy with docetaxel, either alone or in combination with zoledronic acid, or with zoledronic acid on its own. And the comparator, the control arm, has been standard androgen deprivation in most patients with GnRH agonists. The trial has recruited approximately 60% of metastatic cases and 40% who were high-risk localized cases on a 2-to-1 basis, 2 in the control arm to 1 in the active treatment arm. The study recruited its cohort in 2013, and whilst the study has been ongoing, we have been following these patients to look at their outcomes. And these outcomes were reported recently at the world's major oncological meeting at the American Society of Clinical Oncologists, which was in Chicago this year. The trial management team were fully represented and the presentation was made by Professor Nick James, who's consulting clinical oncology in Warwick, in Birmingham. And he's the principal investigator for the trial on behalf of the trial management group, with the coordinating centre being the Medical Research Council Clinical Trials Unit in London. The results of the study have been groundbreaking and have shown a major difference in survival in patients with high risk or metastatic disease. Looking all together at the improvement in survival for M0 and M1 patients, we have an increase of 10 months. Now this was in docetaxel treated patients. What we found when we looked at the patients receiving zoledronic acid alone, there was no specific advantage. For those with zoledronic acid and docetaxel, again, there was a 10-month improvement in survival, but that was largely driven by the docetaxel, and the zoledronic acid was not thought to be contributing to that specific aspect of the patient's improvement in their outcome. We did a planned sub-analysis for the metastatic patients for M1 disease. Remember, that was 60% of the patients altogether. And what we found was an enormous improvement in survival advantage. This was 22 months for patients receiving docetaxel at first presentation. This is a survival advantage which is bigger than most cancer trials and bigger than any we've seen in solid tumours in recent years. There are substantial implications for urological oncology in the implementation of this. What it means is that all patients with metastatic disease at first presentation should be considered for cytotoxic chemotherapy. And if they're fit, and if they want to receive that treatment, then they should be offered it. There are other major implications for how high-risk and advanced prostate cancer at first presentation is managed. We now need to include all of these patients in oncology clinics, and that brings with it questions of how we provide that kind of service and how urologists, as a subspecialty in urological oncology, should manage the cases. The implications for workload are quite significant and substantial. We have the question of how In centres, we can subspecialise into prostate cancer. We have what is an even bigger question in my view, which is how in the district general hospitals, who are currently providing such an essential role in the management of advanced prostate cancer, how they are able to gear up to get sufficient medical oncology of a specialised nature into their practice, and how urologists in general can become trained in identifying patients who are suitable for chemotherapy and for the delivery of care, either in centres which are local to their geographic location, or actually out in those district general hospital locations, so that the patients get the best standard of care no matter where they live. For the future, we probably have to redraw the paradigm for how we manage advanced prostate cancer of this type, and even to consider how we bring this into specialist prostate cancer MDTs, whereby patients are considered for systemic therapies right at the outset in a much more detailed way, and for how they're brought back into the MDT as their disease progresses, as it will inevitably in most cases, so that the patient gets the optimal treatment options, so that they get the timing questions discussed, and so that their urological complications, which we know will happen in at least a third and probably more of those cases as they progress down the journey of prostate cancer, how they are best managed by a multidisciplinary team. Thank you very much.